Good afternoon, everybody. We have an interesting 2-hour meeting where we'll discuss the challenge with the CD30 lymphoma, looking at different clinical cases.
We subsequently know that the key one, a monoclonal antibody recognized CD30, which is expressed by Hodgkin-Reed-Sternberg cells. And we now know that the CD30 antigen is a member of a very large family of tumor necrosis factor receptor superfamily. What's interesting and has really been evolving over the last 2 or 3 years is that actually determining CD30 expression has become very important in a whole range of different lymphomas. It's become increasingly clear that CD30 is expressed in a range of non-Hodgkin lymphomas.
A typical patient, male patient in the early 30s, so when Hodgkin's appears, and had presented with stage 4B disease with liver involvement and disseminated lymphadenopathy, and was treated with ABVD, responded very nicely, and entered into complete remission after 6 cycles. So this is an early relapse. It's close to primary progressive disease. Only 6 months later, he again developed chest pain and B symptoms, and PET scan showed again disseminated lymphadenopathy, so a relapse. And he presented then with lung involvement, so stage 4 disease, again B symptoms, critically ill. So we have a difficult situation right here.
And what will you do at that time? Can you vote on the next question, please?
The last year started a phase 3 randomized trial, multicenter trial, called ECHELON-1 in untreated advanced Hodgkin disease patients to compare ABVD for 6 cycles versus AVD plus brentuximab vedotin for 6 cycles. Probably next year there will be the final result concerning the EHA trial. It's a phase 3 trial in patients who obtain a complete response after autologous transplantation after the second line salvage treatment. But at the same time, there are some studies on the combination of brentuximab vedotin with bendamustine, for example, with DEP, the BRAVE trial, and also with RISE in the United States, in first relapse or refractory patients with Hodgkin lymphoma.
And you need really to have experienced pathologists, good immunostaining, and quite a lot of experience to see where you can fit your patient, because some of them will need a different type of treatment.
In Manchester, we've treated almost 100 patients with the drug brentuximab vedotin, and this was actually the first patient we treated. He was having progressive disease through the EHA chemotherapy with enlarging of his lymphadenopathy and large cutaneous lesions. And the SGN-04 study, the one that we'll be talking about in a moment, was just about to be opened, and this man became the first patient to go onto the study. So this is a man with 2 relapses, profound progressive disease, growing through ESHAP and really very unwell.
Now we have a new drug, different way of action, and I think the door is still open, but that's a very interesting question.
At this point, we did high phosphorus containing regimen for 2 cycles, and at the end of these 2 cycles of we obtained a good partial response. And we decided to use a consolidation treatment with lenalidomide for 12 months.
If you have an overlook over strategies, if you want, and we are talking about the last decade or so, we have tried in the Nordic group to have a strategy looking in the first place at the consolidation that in our context was done after induction of CHOEP. There is now a focus on the CD30 positive lymphomas, not just the ALCL and Hodgkin. And as we already heard earlier in the symposium, there is a whole range of cases that express some degree of CD30.